Today we'll discuss diagnosis and management of rhegmatogenous retinal detachment. So the focus is on rhegmatogenous detachment. Traction retinal detachment and other retinal detachment will be discussed in other lectures. So what is the definition of retinal detachment? You know that the neurosensory retina and retinal pigment epithelium are different origins. And therefore, there is a potential space between retinal pigment epithelium and neurosensory retina. So what happened in retinal detachment is separation of the sensory retina from the retinal pigment epithelium with an accumulation of fluid in the potential space between them. In rhegmatogenous retinal detachment, rhegma in Latin means tear. So in detachment due to retinal tears, the fluid gains access to this space through retinal break. Looking at the incidence of rhegmatogenous retinal detachment, which is supposed to be the most common type of retinal detachments that we are seeing in the emergency room, the incidence is 1 per 10,000 of the population each year. Keep also in mind that it can be bilateral in 10% of the cases. That's why we always, before I examine the eye, the symptomatic eye, I look carefully to the fellow eye. Because frequently the fellow eye either has detachment or has lesions that need prophylactic treatment. If you look at retinal break, there is a high incidence of finding retinal break in the general population. Asymptomatic breaks, 5%. What does this mean? Not all retinal breaks can progress into detachment. That's why we have to know what are the risk factors of a break progressing into detachment, and these breaks that are at high risk of causing detachment need prophylactic treatment. We don't need to treat prophylactically a retinal break that you detect accidentally on routine examination in the clinic, and that's what we shall discuss today. There are physiologic factors that maintain retinal attachment. In the past, when I was doing research in BOPs, it is not easy to separate the retina from the retinal pigment epithelium because there are forces that keep the retina attached. And these are that the outer ends of the retinal photoreceptor cells interdigitate with the macrovillus processes on the inner surface of the retinal pigment epithelial layer. There is adhesive-like mucopolysaccharide containing matrix adhering the retina to the retinal pigment epithelium. There is also active ion and water transfer by retinal pigment epithelium from the subretinal space in the choroid. We are familiar with the fact that, for example, if you have exudative retinal attachment to VKH, if you control the inflammation of the choroid, retina will attach again. Why? Because the retinal pigment epithelium, once it regains function, it pumps out excess fluid. If you have rhegmatogenous detachment, if you close the break with a bucket, next day the fluid disappears because of the pump function of the retinal pigment epithelium that will pump the fluid into the choroid. And there is oncotic pressure gradient, and there is hydraulic force of the vitreous. This is a diagram to show you. These are the retinal pigment epithelium. You see we discussed this in basic science, villus processes of the retinal pigment epithelium, and then you see the outer segments of the photoreceptors interdigitating with this villus process. So what are the factors that cause rhegmatogenous detachment? You need a break. But usually, these breaks are caused by BVD. As I said, asymptomatic breaks, the risk of detachment is very low. So you need a break caused by BVD. You need vitreoretinal traction. When you have the horseshoe tear induced by BVD, the pseudohalide remain attached to the flap of the tear, causing persistent vitreoretinal traction. And then you need intraocular fluid currents that will allow the fluid to pass through the peak. You need three things: break, vitreoretinal traction, and intraocular fluid currents. And retinal detachment develop if these forces exceed the forces that keep the retina attached. So if we look at the pathogenesis, so as I said, you need BVD, right? Pseudo-vitreous detachment. That's why, keep this in your mind, any condition associated with increased prevalence of vitreous liquefaction and BVD, or with increased number and extent of vitreoretinal adhesions, is likely to be associated with a higher incidence of retinal detachment. So all the risk factors for retinal detachment are summarized here. Any condition that increases the risk of vitreous liquefaction and posterior hyaloid detachment, or increasing the risk of pathologic vitreoretinal adhesions, will increase the risk of retinal breaks and retinal detachment. Is that clear? Now then we'll see, what are these factors? Myopia. Myopia increases the risk of early BVD. You see myopic detachment in very young people. Cataract surgery increases the risk of early BVD. Familial predisposition like Stickler syndrome increases the risk of BVD. History of retinal detachment in the fellow eye. A patient with fellow eye retinal detachment is at higher risk of having early BVD and retinal detachment, and vitreoretinal abnormality. So what happens? There is vitreous liquefaction followed by BVD, resulting in vitreoretinal traction and retinal breaks. And breaks can develop at visible sites of vitreoretinal abnormalities such as lattice degeneration, but breaks can also occur in an area of the retina that looks normal. Vitreoretinal traction near a break and or intraocular fluid currents will cause retinal detachment. Now, what are the retinal degenerations that are known to be associated with retinal breaks? Most common is lattice degeneration, less common cystic retinal tufts, least common degenerative retinoschisis. So to summarize, we have liquefaction of the vitreous gel under pathologic conditions. Fluid pass through a break in the posterior vitreous cortex, separating the cortical vitreous from the retina. So posterior vitreous detachment, again and again, is a crucial event leading to retinal break and detachment. What does this mean? If you see a patient with complete BVD, and you should be able to see it on the slit lamp, the posterior as an undulating line, completely separated from the retina, you can tell the patient you are protected against retinal detachment. So complete BVD is protective. So at the time of BVD, you can have traction on areas of retinal adhesions that cause retinal tears, and the prevalence increases with age. However, there are diseases that can increase the risk of early BVD, like myopia, trauma, patient have vitreous hemorrhage, vitritis. I'm seeing many patients with Behçet disease, very young, because of the previous vitritis, they have early BVD. So this diagram will show you the pockets of vitreous liquefaction, and the fluid, this fluid can pass through a tear in the posterior vitreous cortex, separating the retina, the vitreous from the retina. If there is an area of pathologic vitreoretinal adhesion, then you will have retinal tear, and you can have bleeding if there is rupture of a blood vessel crossing the retinal tear. So, posterior vitreous detachment has symptoms, which are flashes and floaters. So, flashes and floaters are not symptoms of retinal detachment. They are symptoms of detachment. So, presence of both floaters and the flashes is associated more strongly with BVD and the breaks than the presence of either alone. Shower of floaters, or what's called reddish smoke, can indicate associated vitreous hemorrhage. Vitreous hemorrhage can be found in 13 to 19% of patients with acute BVD. And about 15% of patients presenting with acute symptomatic BVD, meaning coming to the emergency room with flashes and floaters, have retinal tear. This is a very heavy responsibility for those who are covering the emergency room. If a patient comes with flashes and floaters, 50% of these patients have retinal tear, and these retinal tears are high risk. Breaks occur more from, the retinal tears can develop from 1 day up to several months after the first symptomatic BVD. So one examination is not enough to rule out retinal breaks. You have to see the patients also in another appointments to make sure that the patient is not developing up to several months, is not developing retinal tear. The other important statement is that acute BVD with vitreous hemorrhage has 70% a chance of retinal tears. So the presence of hemorrhage at the time of BVD increases the risk of having retinal tears. About 70% of the patients will have retinal tears. And this is compared to 2 to 4% in acute BVD without vitreous hemorrhage. The presence of pigmented cells, look carefully at the patient. If you see pigmented cells in the vitreous or anterior chamber with no previous ocular surgery or trauma, suggests retinal detachment or tear. So two things that you have to look carefully at. If there is vitreous hemorrhage, high risk for retinal tear. If there is pigmented cells in the vitreous and anterior chamber, increased risk of having retinal tear. So how would you examine this patient who comes to the emergency room with symptomatic BVD? You have to do careful examination with indirect ophthalmoscopy and scleral indentation. We have to master this technique. And then every 3 to 4 months during the first year. If the patient had vitreous hemorrhage or pigmented cells or retinal hemorrhage or peripheral vitreoretinal abnormalities, then you should examine the patient in 1 or 2 weeks and then at regular intervals for 6 months. Patients with dense vitreous hemorrhage, they need ultrasound and hospitalization. We position the patient head up, allowing the blood to gravitate down to allow us to examine the retina. Now, if you see the patient and the patient had complete BVD, then you tell the patient there's no risk anymore to develop retinal breaks or detachment. Symptomatic BVD, what I mean by symptomatic BVD, associated with flashes and floaters. This is symptomatic BVD. Symptomatic BVD in phakic eyes has a higher risk than in phakic eyes of inducing retinal tears. So this is just a diagram to show you. So this is a flap tear. You see the flap? The flap of the tear, when you see flap tear, it's always the result of BVD. The flap of the tear is always attached to the posterior hyaloid. And during vitrectomy, for these cases, I always excise the flap of the tear to relieve the traction. And then you can have the restriction around the tear. So this is risk for RD. And then you can have the fluid current that will force the fluid to pass through the tear. So you need a break at the time of BVD, caused by BVD. You need traction around the tear by the posterior hyaloid, which is remain attached to the flap of the tear, and you need the fluid current. You can see this is a lattice degeneration, and frequently we see flap tears at the edge of lattice degeneration. This is another to show that the accumulation of subretinal fluid. So 60%, what are the predisposing peripheral retinal degenerations? 60% of the breaks develop in area of peripheral retina that show specific changes, mostly lattice degeneration. But we can see breaks developing in part of the retina that looks healthy. So spontaneous breakdown of the thin retina cause a hole, and acute BVD will cause tear. Lattice degeneration is the most important visible fundus lesion predisposing to retinal tears and detachment. It is clinically characterized as a sharply demarcated area, most commonly circumferential oriented. Sometimes they are radially arranged along vessels with crossing white lines which represent hyalinized blood vessels. So what happened in lattice? There is liquefaction of the vitreous gel over the lattice, and there is a strong attachment between the posterior hyaloid and the margin of the lattice degeneration. So when there is posterior vitreous detachment, there is a retinal break at the edge of the lattice degeneration. So these are the lattice degeneration. You see these white lines that represent hyalinized blood vessels. It can have also small atrophic holes, we'll discuss later. And then you can have a flap tear at the edge of the lattice because of the strong adhesion between the posterior hyaloid and the edge of lattice degeneration. And this is the radial lattice degeneration. So lattice degeneration are found in 8% of the population, bilateral in 33%. It is more common in myopic eyes. That's why myopic eyes are more prone to develop retinal detachment. The incidence increase as the axial length increase. And lattice is present in 20 to 30% of retinal detachment cases. So, if you have lattice degeneration in 8% of the population, this means that not all lattice degeneration can progress into retinal detachment, right? So it is wrong. We see this. To do prophylactic treatment for lattice degeneration as routinely. You don't need it, because not all this lattice degeneration will develop retinal detachment. So only a small number of individuals with lattice develop retinal detachments. Therefore, we have to know what are the indications for prophylactic treatment of lattice degeneration. So lattice degenerations can be associated with round atrophic holes, and this is, again, still a very low risk to develop to progress into retinal detachment. We have to only to observe it. So small round atrophic holes within lattice degeneration, this is a low risk for detachment. They can progress into detachment, but this is not common. But retinal tears at the edge of lattice degeneration induced by BVD, this is associated with a very high risk of retinal detachment. Keep in mind that retinal tears can also develop in area which looks normal. The other degenerations that can be associated with detachment is degenerative or senile retinoschisis. It is a degenerative phenomena. It is age-related. It can be seen in 31% of population at the age, over the age of 40. The retina is split into two layers by a viscous substance full of hyaluronic acid, very viscous. That's why when the patient moves, you see the schisis cavity moves like they call it jelly-like movement. When you have حلوة الجيلي في طبق بتتحرك كده لها special movement. The hyaluronic acid rich fluid of the schisis cavity will give you similar movement. We can have two types: the typical, which is split in the outer plexiform layer, and the reticular split in the fibril layer. It is temporal, infratemporal in 70% and supratemporal in 25%. It is very rare cause of retinal detachment. You can have outer layer breaks, and you have inner layer break. Breaks in the outer layer can cause detachment if the hyaluronic acid rich liquefies. And you can have detachment if you have breaks in the two layers. Like this drawing, you can see here the holes in the inner layer, and this is large break in the outer layer, and this is a clinical case. You can see the outer layer breaks are usually very large. We don't treat prophylactic retinoschisis unless the one eye develop retinal detachment, and then you treat the fellow eye, you apply prophylactic laser to the outer layer breaks, and even sometimes you might need to surround the area of schisis with prophylactic laser foot coagulation. This is an example of you have liquefaction of the fluid in the schisis cavity that can pass through the outer layer, inner layer break, outer layer break, causing retinal detachment. So a risk is low. You just need to observe unless a patient develops retinal detachment in the fellow eye. Myopia, again, increased risk of retinal detachment. We know that the lifetime for retinal detachment for a person with more than 5 diopters who lives to the age of 60 is 2.4% compared to 0.06%. So many-fold increase in the risk of detachment in patients who have myopia more than 5 diopters. Myopes have 42% of all retinal detachment, and myopes make only 10% of the population. So myopia increases the risk of detachment. Why? Because there is increased risk of vitreous liquefaction and early posterior vitreous detachment. There is also, myopes have more lattice degeneration, and the peripheral retina is thin. Aphakia and pseudophakia, cataract surgery by any means increase the risk of retinal detachment. Not only cataract surgery, but also YAG capsulotomy. Because cataract surgery increase the risk of liquefaction of the vitreous. So cataract surgery increase the risk of liquefaction, and BVD, again, BVD. So any conditions that increase BVD, and this is due to loss of adhesion of vitreous to the pseudo capsule at Wigner's ligament, will increase the risk on the retina, traction on the retina when the eye moves. Again, that's why I always say that you should do capsulotomy unless it is really necessary, because YAG capsulotomy increase the risk of the retinal detachment. Blunt trauma increase the risk of detachment. This is usually a cause of detachment in young people, and it is associated with avulsion of the vitreous base, and you can have a dialysis. And this is avulsion of the vitreous base. This is dialysis, separation of the neurosensory retina from the non-pigmented epithelium of the ciliary body. And the interval between the trauma and the detachment can be long. The detachment in these patients is usually slowly progressive. Why slowly progressive? Because the vitreous is still attached, because the vitreous is healthy. So this is a chronic type of detachment. Patient usually present with multiple demarcation lines, sometimes retinal cysts. And but the prognosis, the anatomic prognosis for these cases is good. The dialysis usually develop supranasally and infratemporally, traumatic dialysis. Now, I always say that if you see a child with detachment, it is a stickler until proved otherwise. All the residents who rotated with us, I always give them this information. So stickler is a major cause of detachment in children, dominantly inherited. There is defect in development of type 2 collagen, and the patients, the children have optically empty vitreous. When you look carefully with inductive ophthalmoscopy, there is a lot of transvitreal membranes. They can have cataract, lattice-like changes. The globe is large, very large axial lens, and the risk of detachment is very high. And the detachment in these children is usually very complicated, especially with giant tears. في أجازة العيد, I operated one child. The patient that you asked me to operate, he was a child with a stickler, and he had 2 large giant tears. Alhamdulillah, we operated him. You know, giant tear retinal detachment, the success rate, anatomic success rate is very high, provided that there is no BVR. So the child had 2 giant tears. He has a stickler syndrome, and we flattened the retina, but we have to do prophylactic treatment, 6-degree laser photocoagulation for the fellow eye, because the risk is very high. So this is the British example of a stickler. This is a picture was given to me by Allah yarham, Mr. John Scott. Mr. John Scott from Cambridge, he's the one who introduced silicone oil for vitreoretinal surgery. And he has a special interest in stickler syndrome to the extent that I learned the stickler syndrome from him. He had a club for patients with this syndrome. يعني كان متعاطف جدا مع المرضى children will become adult who have a stickler. So if you look carefully, they can have hearing impairment, and they have hypoplasia of the mandible for the maxilla, and poorly developed nasal bridge. They have high arched palate, and this is a Saudi stickler child from Mecca. You see here, he lost this eye. He developed retinal detachment in the first eye. He was seen in another hospital who just said this is chronic retinal detachment, and they didn't do anything for the fellow eye. Although he needed prophylactic treatment, I operated the fellow eye. You can see that the eye is still injected. using silicone oil tamponade, but also you can see the poorly developed nasal bridge, the hypoplasia of the mandibles, hypoplasia of the maxilla, the high arched palate. And this is the eye that had chronic retinal detachment, and this is the eye that we operated, and then we removed successfully silicone oil. So when you put the child on a slit lamp, then focus behind the lens, then you can see fine vitreous fibrils and optically empty vitreous. And this is again another one of the important features for stickler. This is the fellow eye of a patient with a stickler. Then you can see the extensive lattice degeneration, and that means that this child needs prophylactic treatment. When we apply prophylactic treatment, we surround the lattice degeneration. It should be broad, and it should be extended from 6 degrees. This is an example of our prophylactic treatment. We surround the lattice and extend it from 6 degrees. Type. If you look at the retinal breaks, the retinal breaks can be horseshoe-shaped tear. So horseshoe tears are the result of what? BVD. Operculated tear, BVD. Round retinal holes, these are holes that develop in atrophic retina, and the risk of detachment in these holes is very low. Giant tears and retinal dialysis. So this is examples of, this is flap tears. Flap tears, you can still, the flap is attached to the pseudohaloid, and these are the tears that cause retinal detachment. And this is operculated. The piece of the retina is completely separated, and the risk of detachment here is less. And these are atrophic holes. Giant tears. Giant tears are not common, and the giant tear develop as a result of BVD. But what happened in giant tear? The pseudohaloid, when it detach, it remains attached to the antiflap of the tear. The posterior flap has no vitreous attachment, and the pseudohaloid is detached, so it is freely mobile, and it can be folded over. And as I told you, in our hands, we had almost 100% success in flattening the retina with giant tears, provided that there is no BVR. When there is BVR, the situation is very complicated. But keep in mind that the fellow eye of a patient that has giant tear has a very high risk to develop retinal breaks, giant tears, and retinal detachment. That's why it's an absolute indication to do 360-degree prophylactic laser photocoagulation for the fellow eye of non-traumatic giant tear. Non-traumatic giant tear. So as I said, horseshoe tears, they develop at the time of BVD, and it is a high risk, there's high risk to progress into retinal detachment. Round holes, they don't progress to retinal detachment in the majority of patients. But in a few patients, usually moderately myopic, more common in women, these round atrophic holes can lead to very slowly progressive detachment. Why again slowly progressive? Because there is no BVD. And usually these patients, they come with demarcation lines and other signs of chronic detachment. It causes slowly progressive retinal detachment. Dialysis, which as I said, usually traumatic, due to trauma will cause separation of the sensory retina from the non-pigmented epithelium of the pars plana at the ora serrata. It is inferotemporal, sebronasal, but most of them are inferotemporal. Sometimes it is bilateral, and this is due to developmental disorder affecting retinal periphery. It causes, again, slowly progressive detachment because the vitreous gel is healthy. So this is an example of a dialysis. Giant tear, as I said, essential retinal tear. If you look at the definition of a giant tear, sometimes they define it as a tear extending of 90 degrees or more. But it's not enough. You can have a dialysis 90 degrees or more. Is it a giant tear? No. It is not only the extent, it is the status of the pseudohaloid. A giant tear, by definition, the detachment of the pseudohaloid remain attached to the anterior flap of the tear near the ora serrata, and the posterior flap is freely mobile. Therefore, it tends to, there is independent mobility of the posterior flap that tend to become inverted. Again, this I'm showing it again for you. This is the typical example. Sometimes I see residents, they are writing in the file of the patient, giant tear. It is not giant tear, it's a large horseshoe tear. It's not a giant tear. This is the definition of a giant tear. Freely mobile posterior flap due to posterior vitreous detachment that tends to be folded over. Now, another type of hole that we see, is not common, is macular hole causing retina detachment. Macular hole causes retina detachment only in highly myopic eyes with posterior staphyloma and retinal atrophy. The detachment, you can see, it's sometimes very difficult to see the hole because of lack of contrast, because there is atrophy at the level of the choroid. So, but the detachment to start at the macular area and then spreads inferiorly. So keep in mind, macular hole is not a common cause of detachment. When it causes detachment, it is mainly in highly myopic eyes with posterior staphyloma and retinal atrophy. And this is an example of a macular hole. And can you appreciate the fluid under the retina? Now, another special type of detachment that I personally operated not many patients, like not more than 10 patients, is detachment associated with Coital Coloboma. So this is a coloboma of the iris, and this is a patient who had detachment, and you can see Coital Coloboma. So Coital Coloboma, how does it cause detachment? If you don't know the pathogenesis, you cannot operate the patient. The detachment always develop in the atrophic retina in the bed of the coloboma. So when you operate, we always do vitrectomy and deflatten the retina. You can see here this is post-op. You can see the and then we apply laser treatment at the edge of the coloboma. And I always excise the atrophic retina in the bed of the coloboma. So this special type of detachment that need a special surgery. So this is another, can you see the laser scars? Another type of detachment that we see, and you have to not to miss it, patients who have involuted retinopathy of prematurity, self-involuted ROP. They remain at high risk of detachment for the rest of their life because of peripheral thin retina and lattice-like degenerations. The only clue to help you to know that this is related to involuted ROP is temporal macular dragging. Like in this patient, he presented with bilateral detachment. You see here the fovea, there is dragging. And here also. So patients with involuted ROP, they can develop, this patient was 40-year-old. So we divide retinal breaks into symptomatic breaks. Symptomatic breaks means they are associated with flashes and the floaters, and these are the breaks that cause the detachment. Or asymptomatic breaks that you detect accidentally during routine examination, and the risk of detachment is very low. You don't need to treat a symptomatic break that you detected accidentally in the clinic. So how will you do? Another point that you find that there is a strong association between open-angle glaucoma and rhegmatogenous detachment. And frequently we diagnose open-angle glaucoma after we flatten the retina. So there's a lot of details about it. And then, when you evaluate a patient with detachment, ask about symptoms of flashes and the floaters, which are present in about 60% of the patients with retinal detachment. So flashes and the floaters, just symptoms of posterior vitreous detachment. But what are the symptoms of detachment? Visual field defect, dark shadow, curtain or cloud. These are the symptoms of retinal detachment, and loss of central vision if the macula is affected. Signs, look for relative apparent pupillar defect. Intraocular pressure is usually lower in the eye with detachment. If the eye is soft, we see this frequently, it indicates associated choroidal detachment. And these are slightly complicated cases. And two chamber, you would expect to see pigmented cells in the anterior chamber, but if the detachment is neglected, I have operated recently one patient who has fibrinous reaction in the anterior chamber and severe hypotony. So you can have anterior segment inflammation. If you look at the vitreous on the slit lamp, look for pigmented debris, tobacco dust, and absence of pigments suggests another diagnosis. Frequently, so the presence of rhegmatogenous detachment or retinal tear is associated with tobacco dust or pigmented debris in the anterior vitreous. If you don't see pigmented debris, think about another cause. So this is examples of the retinal breaks and retinal detachment. So what are the signs of long-standing? In the emergency room, you can see a patient with retinal detachment, and the patient you ask him what is the duration of the detachment. He tells you only 1 week. But you should be able, by looking at the retina, to know what is the exact duration of the detachment. Because there are signs of long-standing detachment. Retinal thinning, retinal cyst. Retinal cyst needs 1 year to develop. I operated one patient with retinal cyst, and she told me, well, the detachment only for a few weeks. But if there's a cyst, this is, it needs 1 year to develop. Subretinal demarcation line needs 3 months to develop subretinal fibrosis. So this is a drawing to show you the pigmented demarcation line, which needs at least 3 months. It's a sign of chronic, slowly progressive detachment in patients with attached posterior hyaloid. And usually you can see atrophic holes. Retinal cyst, as I said, it needs 1 year to develop. This is post-op patient, and you can see the demarcation lines. Lenkoff rules, you need to read it in the book. Lenkoff rule, which tell us that the distribution of the subretinal fluid depend on the location of the break, gravity, and anatomic landmarks such as the optic nerve and ora serrata. So, for example, if you see that the fluid distribution is like this, you would expect to see the break here. The fluid distribution like this, expect to see the break in this location. So this is, you need to read about it in your book. Now, the classic technique to repair fresh retinal detachment is scleral buckling. Scleral buckling, there's no time that I can explain to you, but scleral buckling means that you close the break from outside by suturing a sponge to the sclera from outside opposite to the break that will cause indentation to close the break and relieve traction. This is the idea of scleral buckling. So that means that to put the buckle in the right place, you have to do accurate localization of the break on the surface of sclera. We need for this Ocular localizer. This is, so you need to master indirect ophthalmoscopy with indentation. You indent with Ocular just opposite to the break. And then you put a mark on the sclera, a blue mark on the sclera corresponding to the break. Is that clear? That is, for example, a small horseshoe tear, you need only 1 mark at the apex. If it is large, you need 1 mark at the apex and 2 marks on the sclera at the base. And then you need to apply retinopexy. You can use cryo or diathermy. I'll show you how to use the diathermy. And then you need to suture. This is the tear. Huh? We had a mark here, and we have 2 marks here, horseshoe tear. And then you need to fix the sponge. This is radial sponge. Then you need to use sutures. And the sutures, for example, if you decide, because of the size of tear, to use 5 millimeter sponge, so the distance between the 2 arms of suture should be 2 millimeter more than the size of the sponge. And the posterior bite should extend 3 millimeter behind the posterior localization, and the anteriorly should extend 2 to 3 millimeter anterior to the tear, so that you make sure you give full support of the break. If you are dealing with a dialysis means circumferential buckle like this. In the past, this is Skibben's technique. We used to put the buckle under scleral flap. So we dissect scleral flap, half thickness. We put the serum in the bed of the flap, and then we put the buckle in the bed of the flap and suture the flap. So this is an example of radial buckles to support this. So this is ideal situation. This is too small. This is a circumferential buckle. If you are dealing with rounded holes or dialysis, you can combine circumferential with radial buckles. If you are dealing with a giant tear, BVR, macular hole, then you need Barzimelin vitrectomy. And nowadays, we do what's called primary Barzimelin vitrectomy for complicated cases with fresh retinal detachment. This is called primary Barzimelin vitrectomy. Now, if we want to assess the risk, we have still time, Tim. If we want to assess the risk of a retinal break to progress into detachment, this is very important. We know that retinal detachment occurs in 1 to 10,000 of population per year. But if you look at clinical studies and autopsy studies, 5 to 14% of the general population have retinal breaks. So what does this mean? Not all retinal breaks progress into retinal detachment. So only 1 retinal detachment will develop from every 70 breaks. So our rule now is to identify which breaks are at high risk of detachment that need treatment. So we look at history. A family history or a history of retinal detachment in the fellow eye increase the risk. Patient had cataract surgery or posterior capsulotomy, increase the risk. Acute symptoms of flashes and floaters increase the risk. So these are points that you should look in history to see if this retinal break need treatment, prophylactic. I'm talking about prophylactic treatment, meaning break and retina still attached. Examination. If the patient is highly myopic, this increases the risk. If the tear is horseshoe tear associated with BVD, increase the risk. If there's associated limited retinal detachment around the break, what we call subclinical detachment, increase the risk. So what is the definition of subclinical retinal detachment? That it means subretinal fluid extending at least 1 disc diameter from the retinal break, but no more than 2 disc diameter posterior to the equator. Why it's called subclinical? The patient is not aware of it. There is no visual field defect. Again, we are still talking about assessment of risk. Non-myopic, phakic eyes in patients without a family history of retinal detachment and without prior retinal detachment in the fellow eye are unlikely to develop retinal detachment regardless of the presence of retinal pathology. Is that clear? I'm focusing on this because I'm seeing many patients seen by other colleagues, and they treat small rounded holes, asymptomatic breaks, without a family history, without history of retinal detachment in the other eye, without high myopia, without having cataract surgery. Again, assessment of risk. Horseshoe-shaped tears or flap tears with persistent vitreoretinal traction are far more likely to cause retinal detachment than are round holes with free operculum or round atrophic holes. So again, horseshoe tears with persistent adhesion between the pseudohyaloid and the flap of the tear. Round atrophic holes can cause retinal detachment mainly in young myopic patients without BVD, but this is very rare. As breaks have a far lower risk of causing retinal detachment than new breaks detected at the time of symptomatic BVD. About 10% of patients who have retinal detachment in one eye will develop detachment in the fellow eye. So, detachment in one eye increases the risk of detachment in the fellow eye. Eyes without BVD have a higher risk of retinal detachment than eyes with BVD. Did I tell you this? If a patient has complete BVD, no risk. You can tell the patient, you can assure the patient, no risk. But if the patient still have BVD, you can tell the patient if they had detachment in the fellow eye, there is still risk. The fellow eyes of patients with idiopathic giant tears. I told you before, idiopathic non-traumatic giant tears in one eye, there is high risk of retinal breaks, giant tears, and retinal detachment in the fellow eye. So this is absolute indication to do prophylactic treatment in the fellow eye. Patients with Stickler syndrome, they have high risk of retinal detachment. So what are the indications for prophylactic treatment? So far, is it clear? Acute symptomatic horseshoe tears result in retinal detachment in 25 to 90% of the eyes. That's why acute symptomatic horseshoe tears should be. Asymptomatic dialysis, which is usually located in the infratemporal quadrant, associated with a high rate, so dialysis should be treated. Acute operculated tears. What do I mean by operculated tears? The flap is totally separated. Acute operculated tears occurring at the time of symptomatic BVD with persistent traction near the tear might need treatment. The fellow eye of idiopathic giant tear need treatment. Treatment not indicated. Treatment not indicated. You don't need to treat. Asymptomatic breaks in patients without history of retinal disease. Lattice degeneration. Myopic patients with lattice should return immediately for examination if they develop symptomatic BVD, but you don't need to treat. Lattice with holes. If you have lattice with atrophic hold, the patient should be re-examined at 6 months interval. Don't need to treat. Myopic eyes with asymptomatic breaks. You don't need to treat. Degenerative retinoschisis. You don't need to treat. Breaks with subclinical retinal detachment are at low risk of progression to clinical retinal detachment. So to prevent or to treat, you need to apply, we always now use laser. You need to apply two rows of laser around the retinal tear. You can use also cryopexy, but very rarely now we are using cryopexy. Differential diagnosis of retinal detachment, choroidal detachment. We had a patient in the ward who had the retinal detachment after vitrectomy for diabetic vitreous hemorrhage. The choroidal detachment is different from retinal detachment. It is a smooth elevation, not corrugated, and does not move. And this is the example of a choroidal detachment. Traction retinal detachment. This is typically seen in patients with diabetes. The retina is not mobile. It has concave configuration. It rarely extends the but these patients, they can have combined detraction and rigidity detachment. And in this case, you will see that the configuration will change. Another important issue here is the presence of hydration lines. Hydration lines are pathognomonic for rhegmatogenous detachment. You never see it in oxidative detachment. You never see it in pure traction detachment. This is what I meant by this patient had combined detachment. You see the hydration lines. Oxidative retinal detachment, you should, like in Vogt-Koenig-Harada disease, if it is neglected, then patient can come with bullous oxidative detachment. It has a convex configuration, smooth, not corrugated. Retina can be seen behind the lens. So this is an example of oxidative retinal detachment due to Vogt-Koenig-Harada disease. Choroidal melanoma can be associated also with oxidative retinal detachment. Any question? So now what I want to, for everyone in this room to know the relation between the pseudohyaloid and retinal breaks, which retinal breaks are at high risk for retinal detachment, and which retinal breaks can be treated. The main conclusion is that not all retinal breaks need treatment. You should divide the breaks into low-risk breaks. Usually these are small atrophic holes, asymptomatic eyes detected on retinal examination. It can be treated with lattice. You don't need to treat prophylactically. But symptomatic breaks means breaks that occur at the time of BVD, that are associated with flashes and the floaters. These are the ones that you need to treat. Giant retinal tear, idiopathic giant retinal tear, or non-traumatic giant tear, you need to treat the fellow eye because the risk to involve the other eye is very high. The children with Stickler syndrome, they need prophylactic treatment. Shukran.
shut off the screen a second?
You want?
Shut this off so I can turn on the presentation. Okay.
It's ready to this computer.
It's freezing in here. Yeah, you can go.
Assalamu alaikum. Good afternoon. Today, Dr. Semidi, he's going to present us post-operative vitrectomy and ophthalmitis. Dr. Semidi has been working here in KKESH almost 3.5 years, and I think we can already call him a veteran surgeon here. And let's hear what he's going to tell about the post-operative post-vitrectomy and ophthalmitis.
Hi, good afternoon, everyone. Thank you, Dr. Ibrahim, for the introduction. I'm Dr. Valmor Semidi. I'm working here at the Vitro Retinal Division in King Khalid Eye Hospital. And today we'll be speaking a little bit about endophthalmitis post-vitrectomy. As we will see during this lecture, it's the least frequent type of endophthalmitis, of post-operative endophthalmitis, but it can happen. And usually it appears in clusters, and some controversy surrounds its risk factors and management. Now, very little has been published in regards to this disease, where most of the reports on postoperative endophthalmitis, they focus on post-cataract surgery or bleb-associated or trauma. So bear with me while I do share whatever information we do have available. So as we all know, endophthalmitis is characterized by the presence of severe inflammation of the intraocular tissues and fluids, and usually this is accompanied by severe visual loss. As we can see, the overall incidence has decreased in postoperative cases since the 1800s, where about 1 out of every 10 patients that had a cataract extraction in the 1800s would develop endophthalmitis. In the mid-1900s, about 0.58% of the patients developed infection, and in the early 90s, it went all the way down to 0.09%. Now we see that there was a small spike in the 2000s where the incidence of developing post-operative endophthalmitis, this is in phaco surgery, it elevated to 0.21%. And this was the culprit of this was the apparition of clear corneal incisions. So basically at that point in time, when they appeared, we didn't know how to construct our wounds properly, and this led to an increase in the development of endophthalmitis. So this highlights the importance of proper wound construction. And similar findings were seen with the advent of small gauge vitrectomy surgery, as we'll see later on. So acute postoperative endophthalmitis, in all cases, this is taking into account any type of ocular surgery. Wide, the numbers seem to be consistent in different centers and in different countries. And it ranges from 0.04 to 4% of cases, where post-cataract surgery, the incidence, like we just said in the previous slide, is about 0.12%, post corneal transplant, it's a little bit higher, about 0.38%. Bleb-associated has a very, very wide range. It can be from 0.2 all the way to 10% of our patients. And post-vitrectomy, as we can see, is the least frequent at 0.05%. But a similarity that all these patients have is that no matter what the preoperative condition or what the procedure was for, the endophthalmitis itself carries very poor visual outcome. Now, Auberg, in 1998, he compared the rates of endophthalmitis according to all his procedures, or all the procedures he studied, in over 58,000 patients. And he found that the highest rate was with secondary IOL placement, with the incidence of about 1 in 273 patients for 0.36%, which is very high. Phaco, as we can see, let me see where the pointer is. Yeah. And cataract surgery more than doubled the incidence of vitrectomy at 0.08% for cataracts and 0.04% for vitrectomy surgery. So overall, post-vitrectomy endophthalmitis is highly infrequent. Now this was in 1998. Later on, 12 years later, in 2010, Wyckoff had a very large case series also of almost 57,000 cases, and he found that the incidence in overall developing postoperative endophthalmitis dropped from Auberg's report of 0.09% to 0.25, which is basically a quarter of it. So this is attributed to an improvement in our surgical technique and our intraoperative measures. But still, no matter the reduction in the overall rate of endophthalmitis, the incidence for cataract surgery still more than doubles that one of vitrectomies. So as we would expect, studies that have been carried out for all kinds of postoperative endo, and the incidence in post-vitrectomy has also been taken a look at. The first reports came out in 1984 by Ho and Tolentino, and they had a very high incidence of endophthalmitis, although their sample size was very small. Let's put it here. So their incidence was about 0.14%, but their sample size was only 2,800 patients. And later on, through the years, all the way up to 2011, the incidence slowly went decreasing as we improved our preoperative measures. And it stabilized at about 0.3, 0.4%. Now, with the advent or the creation of small gauge vitrectomy, sharp trocars are used to pierce the conjunctiva, the sclera, and the pars plana. And then we place flexible cannulas, and they're self-retaining, so we don't have to be removing them from the eye. And through these, we insert our instruments to perform the surgery. Now, once the procedure is completed, the cannulas are removed, and the wounds are often, or the intention of small gauge vitrectomy is to leave them unsutured. Now, the potential advantages of small gauge vitrectomy, I'm talking about 23 and 25, but more recently 27 has also been developed. Now, the benefits of having a smaller incision are that tentatively this is a shorter surgical procedure, because we don't have to be performing peritomies and then closing them. There's improved postoperative comfort, less inflammation, less conjunctival scarring, and it is claimed that the patient has faster visual rehabilitation. Now, presumably, these advantages that they have are secondary to the self-sealing nature of the wounds that obviate the need for suturing. So, as it would be expected, studies began to appear in regards to the incidence of endophthalmitis in 20 gauge or in small gauge vitrectomy. And many of these authors, they compared it as well to the incidence that they had in their own case series of 25 versus 20 gauge. And there was one report that they also compared it to 23 gauge. And so the first reports by Sheikh, Kunimoto, Chen, and Scott, they determined that there was a much higher incidence of developing endophthalmitis in small gauge sutureless vitrectomy. One report by Sheikh, he claimed it was 30 times more likely to develop endophthalmitis if you had a small gauge vitrectomy. Then Kunimoto at 12.5 times likelier, 7 times likelier for Chen, and 27 times likelier for Scott. However, these are very small case series, as we can see here. There's only 129 patients in one and 431 patients in the other. So this gives into the theory that endophthalmitis appears in clusters, or what's called a cluster bias. But further on, in the more recent years, Scott, Shimada, and Hu, they determined that there was no increased risk between gauges. Now, the largest study that has ever analyzed this was the Pan American Collaborative Retina Study. And they published their results in 2011. They compared as well 20, 23, and 25 gauge post-vitrectomy endophthalmitis. And we can see that overall, they have very similar results, where 20 gauge had a 0.21% chance of developing endo, 0.29 for the 23 gauge, and 0.22 for the 25 gauge. So they didn't find any difference between gauges. So no matter how the studies were done or what their results were, or the difference between gauges, they all did mention and they all analyzed what were believed to be the major risk factors. And the associated factors for developing post-op endophthalmitis in vitrectomized patients are as follows: an inadequate wound closure and hypotony, vitreous incarceration or a wick, vitreous cavity contamination, associated pharmacotherapy, the learning curve in educational centers, baseline pathology, and the tamponade agent that is used. So let's take a look at each one of these at a closer range. So the first suspicion in post-vitrectomy endophthalmitis cases has to be the wound closure and hypotony secondary to wrongful closure of the wounds. Some cadaveric studies and in rabbits have determined that 20 gauge sutured wounds are more stable than sutureless oblique 23 or 25 gauge incisions. The hypotony created could also allow for the influx of some pathogens into the eye. And some reports using India ink, well, they're very interesting. So basically what they did was they created 20, 23, and 25 gauge incision into cadaveric eyes. And then they drenched with Weck cells. So they drenched Weck cells with India ink, and they placed the Weck cells over the different types of incisions. And then they manipulated the intraocular pressure to go from hypotony, 5 millimeters of mercury, all the way up to 75 millimeters of mercury, and they made this variation. And they found that the eyes that were unsutured, no matter what size gauge vitrectomy they were, post having the IOP manipulation, they tested, the vitreous samples tested positive for India ink. So this means that no matter, their analysis with that, no matter if you suture no matter the size of your incision, the importance is suturing it. And that's what allows the influx of pathogens into the eye. Vitreous incarceration is another risk factor, and we know this also from cataract surgery, right? When you have posterior capsule rupture. So when evaluating the integrity of wound closure with an endoscope, we can see the incarceration of the vitreous cavity in the wound, in the wound of the vitreous. I'm sorry. We can even see this when we're depressing intraoperatively, when we're trimming the vitreous and we're depressing the sclera. If we see our trocar, many times we will see that the vitreous is entering. So imagine after that you remove the trocar, it's logical to have some vitreous incarcerated in the wound. Also, an unsutured wound permits communication of the ocular surface flora with the vitreous cavity through the wick, and this allows for the passage of microorganisms into the eye. Now, vitreous cavity contamination, it refers to the surgeon contaminating the vitreous cavity directly. And how does this happen? Well, one study by Tominga and collaborators, he compared preoperative conjunctival swabs of patients before and after the installation of topical antibiotic. Then he did 20 gauge incisions and 25 gauge transconjunctival incisions. And he took a vitreous sample before and after the vitrectomy in each one of these cases. So the patients that had transconjunctival sclerotomies, as opposed to a peritomy with a 20 gauge incision, these patients that where the sclerotomy was placed through the conjunctiva, 22% of the times their vitreous culture was positive before starting the case. I'm sorry, 22% of the times in the 25 gauge and only 2% of the times in 20 gauge. So why is this? Why do we think this happens? Well, and Propionibacterium acnes was the most common pathogen isolated, in these studies, and it's possibly associated to more instrumentation exiting and re-entering into the eye. So the theory is that if you do a peritomy and remove the conjunctiva, you're basically left in a sterile subconjunctival space. So if you do a sclerotomy there, the likelihood of you delivering pathogens into the eye is much less. Instead, if we go straight through the conjunctiva, the ocular surface flora has a chance of going inside with your piercing. So associated pharmacotherapy is another one of the risk factors. And with the advent of sutureless vitrectomy, some surgeons have stopped administering subconjunctival antibiotics overall. They feel that it is not necessary anymore to deliver antibiotics. Another thing is that we use many medications intraoperatively, like triamcinolone, dexamethasone, and perfluorocarbon liquids. And some of these medications, like the Avastin or the triamcinolone, are prepared by a third party, and we don't know the conditions under which they are prepared. So they could lead to an increased risk of contamination of the vitreous cavity. Now, this is a very important point, and it's the learning curve that we have in educational centers. It's normal to have deficiencies in constructing proper wounds when we're beginning our surgical journey. And this is seen in cataract surgery with the construction of corneal incisions, and sclerotomies, unfortunately, don't escape this difficulty. So there's a learning curve that applies, and proper supervision should be taken at all stages. At the beginning of the surgery while constructing the incisions, and at the end while we're closing them, making sure that the wounds are self-sealed, or if not, that they're sutured appropriately. So also, we have to take into account that at learning centers, there's multiple surgeons touching the eye or involved in the surgery. There's multiple hands on the field, and that means more instrumentation entering and exiting the eye. Also, many residents and fellows have not developed their suturing techniques, so this could lead to leakage postoperatively, to hypotony, and, as we've spoken in the previous examples, the ingress of bacteria into the eye. We also have to consider and take into account that many, as in any surgical procedure, an immunocompromised patient has higher risk of developing postoperative infection. And maybe 90% of the patients that we're operating on are diabetic patients for different types of diabetic eye disease. And this in itself makes them immunocompromised. We also have to take into account that these patients have advanced tractional retinal detachments many times, and this could lead to longer surgical times, more instrumentation being used intraoperatively, and these procedures are sometimes combined as well with cataract surgery. So this creates more wounds and more possible ways for the bacteria to enter the eye. And I think the most controversial risk factor is the tamponade agent. Many people are under the impression that if you place tamponade, any type of tamponade, into the eye, they will be sterile, and there's no way of developing endophthalmitis, and this is not true, as we will see now. So tamponade agents like gases or silicone oil, even air, they have higher surface tension. So this allows for proper wound apposition at the end of the surgery and a better integrity in itself, which in turn can lead to less risk of hypotony and fluid exit or entry through the wound site. So there's also suspicion that these agents do not allow for proper bacterial growth. For example, some studies have immersed different types of microorganisms like staph or strep or pseudomonas into silicone oil, and they have realized that after a period of 7 to 21 days, these colonies that are intended to grow reduce significantly, and in some cases even disappear. So they have claimed that the silicone oil has some sterile nature to it. On the other hand, some studies, they claim that there is severe visual loss in eyes that have endotamponade. Why is this? This is because the microorganisms or the infection, they cannot mix with the gas or with the silicone oil. They cannot penetrate inside of it. So they're basically confined to the area in front or between our tamponade agent and the retina. So this causes severe inflammation of the retinal tissue and consequent damage. Now, the Pan American Collaborative Retina Study Group that we spoke about in the incidence slides, they also were the only ones to analyze a large case series of how how endophthalmitis develops according to the tamponade agent. And they saw that their patients with gas, only 3 cases of endophthalmitis out of 1,000, and that's about 0.14%, which is basically standard for postoperative endophthalmitis. In fluid-filled eyes, the incidence was much higher at 0.78%. Now realize that silicone oil-filled eyes, absolutely none of them developed endophthalmitis. So how do we manage an eye that has a tamponade agent and they develop endophthalmitis? Well, when the eye has been tamponade with gas, usually it is recommended to inject half dose of the antibiotics, and the vitreous and the sample for culture is taken from the anterior chamber, not from the vitreous cavity, because we would just be taking a sample of gas. Obviously, nothing would grow there. So usually it's recommended to inject half-dose antibiotics unless the gas bubble is filling more than 50% of the vitreous cavity. In that case, you could give full-dose antibiotics. Dexamethasone can also be a consideration, as in any case of endophthalmitis. And depending on the severity, a pars plana vitrectomy and washout of the anterior chamber and the vitreous cavity is also an option. Now, when the eye is filled with silicone oil, the normal tendency is to remove the silicone oil, to wash out the anterior chamber, and then deal with your, inject your antibiotics and re-inject oil if you need to, or gas. So the recommendation is to remove this oil that might be contaminated. So it is extremely rare, as we saw in the Pan American Collaborative Retina Study. They reported 0 cases. But there have been some described in the literature. I'm going to mention 4 of them, or the only 4 that have been described. So there was one by Steinmetz and collaborators. They reported 2 cases, and they managed it in a novel way. Instead of removing the silicone oil, they decided just to inject antibiotics into these eyes. And they resolved very quickly and very well. However, there is doubt as to whether these cases were infectious or not, or just a severe inflammatory reaction to the silicone oil, because one of these cases didn't have samples sent for culture, so it was never proven to be an infectious case, and the other just had an aqueous sample sent for culture and it came back negative. This doesn't mean that it is not infectious, but it doesn't confirm it either. So his cases, we will not consider that they were in fact positive for culture. Now, only 3 cases of post-vitrectomy endophthalmitis and with positive culture under silicone oil have been reported. So Chang and collaborators reported a case of post-vitrectomy endophthalmitis caused by Pseudomonas. And they noted clinically the silicone oil was very clear, and there was a whitish material covering the retinal surface. So this case was managed in a conventional way. They removed the silicone oil, washed the vitreous out, and injected antibiotics. And postoperatively, the patient unfortunately did not recover any vision. His vision was lost to no light perception. The second case reported was by Simmer-Galler and collaborators. And this endophthalmitis appeared 3 weeks after vitrectomy for CMV-related retinal detachment. The culture in this case came back for coagulase-negative staphylococcus, and the case was managed conventionally as well by silicone oil removal, antibiotic injection, and re-injection of the silicone oil. Fortunately, this patient had final visual acuity of 2100, which is great, considering. And the third case was by Goel and collaborators, and their case was also positive for the positive culture for Pseudomonas. And this patient had undergone pars plana vitrectomy for an inferior retinal detachment. Clinically, it was much more aggressive. There was a hypopyon, and there was a whitish exudate trapped between the posterior capsule of the lens and the surface of the bubble. So it was managed conventionally with silicone oil removal, pars plana lensectomy, vitreous cavity washout, and instillation of antibiotics. Unfortunately, this patient didn't progress properly, and when they got the results of their sensitivity back, they decided to go in, remove the oil, and inject antibiotics that were sensitive for this, or that were that had been shown to be sensitive for the bacteria in this case. And finally, his visual acuity was pretty decent considering to 2200. Now, recently in our center, we received a case that contributed to our own experience, and soon we're going to report it as well. It's the fourth case with positive silicone oil culture, and this was a 73-year-old male patient, known case of Alzheimer's, and he underwent pars plana vitrectomy with silicone oil tamponade for a chronic inferior retinal detachment at another center. On his 6th day postoperative, he went to his primary doctor, and he was referred to our hospital because he had developed signs of endophthalmitis. His visual acuity was hand motion, near face, there was moderate lid swelling, and all the signs of endophthalmitis. So we diagnosed it and we decided to take him. We did an anterior chamber washout, this sample sent for culture. Then we removed silicone oil and sent the silicone oil also for culture because it was very turbid. And then we washed out the vitreous cavity and sent the washout sample also for culture. We injected half-dose antibiotics into the vitreous cavity and the other half-dose intracamerally. And then silicone oil was re-injected into the eye. And postoperatively, the patient, clinically, he improved very quickly. Unfortunately, visually, he did not. His preoperative vision, not before the treatment of the endophthalmitis, but before the retinal detachment, was already hand motion. So basically, he's back to baseline with hand motion visual acuity. So in this table, we can see some reports that have been published regarding culture positivity. As we know, it's frustrating to get a case of endophthalmitis, and we send the sample to the lab, and many times it comes back negative. So how can we compare this to what has been described in other centers? So most of these case series, as you can see, have very small number of patients, 3, 6, 5. So the largest cases were by Cohen in 95, he had 18 patients, and Abi Ayad in 2007 had 14 patients. But you see the culture positivity ranges widely from 29 all the way to 89%. So it's not very trustworthy that we will have a positive culture in these cases. However, the source of infection is most likely the ocular surface, and we have to take this into account in the next slide that I will show you because of the organisms that grow. This is why proper preoperative preparation and placing of povidone in the fornix will help reduce the bacterial load. Longer cases in current elevated risk due to exposure, longer exposure time, and the possibility of inoculating other microorganisms into the eye. So some studies in rabbits have demonstrated that if you inoculate only 5 microorganisms of Pseudomonas into the vitreous cavity, they can develop endophthalmitis. Instead, if you can inoculate up to 50 million bacteria of Pseudomonas into the anterior chamber, and they will not necessarily develop endophthalmitis. So this is probably due to the avascular nature of the vitreous cavity. It's rich in nutrients for bacteria to grow, and it is away from any other immune mechanisms that can protect the retina or the vitreous cavity against it. So the culture positivity results by these previous studies, they claim, or they state that that Coagulase negative staph is the most frequent organism that can be found, as we can see in all these reports. Although less frequently, some of them report methicillin-resistant Staph aureus, Enterococcus, or Staph faecalis. This study is a 25-year review of all cases of endophthalmitis, not only postoperative endophthalmitis, post-vitrectomy endophthalmitis, but all types of endophthalmitis. And we can see that it's similar to what happens in post-vitrectomy. So 85% of the cases are Coagulase negatives, gram-positive staph. The other 10% is gram-negative organisms, and about 4.5% respond to fungi, where Candida was the most frequent organism that was grown. And we can see that the isolates in this series, in this 25-year series, was predominantly gram-positive, with the majority being Coagulase negative staph, followed by Streptococcus viridans and Staph aureus. And this distribution is very similar to the results published in Bascom Palmer at Wills Eye Hospital and during the endophthalmitis vitrectomy study, where most of the cases were gram-positive, as we can see here. And corresponding, out of the gram-positives, most of them to Coagulase negative staphylococci. Now it's, to my attention, the most important part of this slide is the sensitivity profile of all these organisms. We can see that over 99% of all of the studies were sensitive to vancomycin. and ceftazidime ranged from 80 to 100% of sensitivity. Now, as I've mentioned several times during the lecture today, the visual outcomes in these eyes is generally worse than in other types of postoperative endophthalmitis. Here, we see how the range goes, in a very fortunate case, from 20/40 all the way to no light perception. However, the majority of the cases have hand motion vision or worse, with a very large number of the patients reaching no light perception. Like in Cohen's case, 50% of the patients ended up in no light perception. All three in Auberg's case, no light perception. 4 out of 6 with AFrig in light perception or worse. So it's very frequent to have severe visual loss, unfortunately, after this. And this could be explained by 2 factors. Well, many of our patients have baseline retinal pathology. They have retinal detachments, retinal atrophy. They're already, their blood flow is compromised. They have ischemia. And on top of this, the disease is originated and confined into the vitreous cavity where it directly affects the retinal surface. So how can we prevent this? Taking all these factors that we've spoken about into account, it's important to highlight as well any measures that can be taken to reduce the possibility of developing these complications. So, as usual, we will separate them into preoperative, intraoperative, and post-op. So this is very basic. When we're examining our patient preoperatively, we have to rule out blepharitis or any ocular surface infection. Then we have to clean the eyelids, lashes, and the skin with povidone iodine, different concentrations. We place adhesive drapes over the lashes and skin, and we have to use a proper lid speculum. Intraoperatively, it is theorized that if we displace the conjunctiva before placing the trocar and then allowing it to slide back into place, it will create a wound that is not directly communicated into the ocular surface. The incisions should be beveled and not perpendicular. And at the end of the surgery, we must revise our incisions for leakage. And if there's vitreous incarcerated in the wound, we have to remove it with a cutter. And we should suture these wounds if necessary. Postoperatively, obviously, the most important is to educate the patient as to what type of surgery he had and what his postoperative measures need to be in order to minimize the risk, and to teach him what the signs and symptoms of alarm are in order to allow us for an early diagnosis. Obviously, we can have a better prognosis if we manage it earlier. This allows us to give prompt treatment, no matter if it's going to be tap and injection, a proper vitreous cavity or anterior chamber samples, and vitrectomy if the case is severe enough. So the take-home message of post-vitrectomy endophthalmitis is that the predisposing factors remain controversial, as we can see. Poor visual outcomes are warranted, unfortunately, after a patient has had this type of endophthalmitis. The symptoms develop early on, usually at about day 3 post-op, but most of the reports say that within 5 days or less, they will be developing already the symptoms. There has to be a lengthy discussion in the programs forming vitreoretinal surgeons, and they should be oriented towards proper wound construction and suturing techniques, okay, and they have to practice. The endotamponade agents that we spoke about, they show protective effects on the rate of endophthalmitis, and this is because they have greater surface tension, they help seal the sclerotomies, and they decrease the fluid transit through the wounds. This is obviously a less accommodating environment for bacterial reproduction. It's not that they're sterile, they just help us prevent. And always we have to consider the possibility that what we're facing is not endophthalmitis, and it could be sterile inflammation mimicking the infection. Let's remember that many of our cases are combined with cataract surgery. And even if they're not combined with cataract surgery, we could have an inadvertent lens touch, and this could create inflammation that might be confused. Sometimes we do cataract surgery and there's some cortical or nuclear material that can be trapped in the AC or behind the iris, and we don't see it. And this could also mimic a postoperative infection. And the TAS, or toxic anterior segment syndrome, can also mimic inflammation. And if we've done combined surgery, this could also be a possibility. Now, I know we have many residents and fellows here, and there's a metaphor that I'd like for you to take home with yourself. And it's basically about our journey into the world of practicing medicine and taking responsibility into our own hands. So it says, "It is said that even before a river falls into the ocean, it trembles with fear. It looks back at the whole journey, the peaks of mountains, the long winding path through the forest, through the people, and it sees in front of it such a vast ocean that entering into it is nothing but disappearing forever. But there's no other way. The river cannot go back. No one can go back. Going back is impossible in existence. You can only go forward. So the river has to take the risk and go into the ocean. Only then, when it enters the ocean, will the fear disappear, because only then will the river know that it is not disappearing into the ocean. Rather, it is becoming the ocean. So you are basically the river." And that's a very nice picture I found of that resembles an eye, obviously, with some iris nodules. And this is Dean's Blue Hole in Long Island in the Bahamas, and it's the second largest saltwater hole in the world. Thanks.
Thank you, Dr. Samidi, for this nice presentation. Now I'd like to open the floor for discussion. Any comments, any questions? Yes, Dr.
Thank you, Dr. Samidi. I have a quick question. It's about, is it a trend or a routine to use an intracameral antibiotic
No, it is not. Usually in any type of postoperative vitrectomy, we do not deliver them intracamerally. We just go for a tap-in vitrectomy and we place the antibiotics in the back of the eye. However, in patients where we have silicone oil, the space for the antibiotic to move in the back of the eye is limited, right? Because most of it, 99%, will be occupied by the silicone oil. So we decided to place them into the anterior chamber in these cases.
So not even when you combine it with cataract surgery or secondary IOL?
No,
so
usually
not.
not.
It's not routine.
No,
Nobody
no.
looked into the difference between with or without intracameral
I'm
antibiotic?
sorry.
Nobody looked into the difference for those who were using it?
No,
right?
to be honest, no. I haven't seen any reports of that. I don't know if anyone else has seen.
For us and like both cataract make a lot of difference nowadays to use an intracameral.
You use intracamerally, yeah.
Yeah, intracameral, either ciprofloxacin or Begamox. Some are a little bit more aggressive and they're using the Trimoxy, which is the combination of Begamox with the triamcinolone, but that is injected.
But this is for prevention, right?
For prevention,
Yeah.
but the reason why I'm saying is that because especially the fluoroquinolone works very well for the ocular surface, and most of the contamination occurs during the surgery. So if you give such a medication which lasts for a couple of hours, it takes care of all the contamination and it prevents it from going to the back or to the front, to any place. So some are, I mean, like it's like a routine for us, most of us in the States, in the Ascaris Society, Ascaris Society, and I'm sure you know about the 20,000 the big clinical study that came up with the conclusion that it's a must for us.
Yeah.
So
Yeah,
maybe
so
one
so
thing
that's a
that
great
needs to be
measure
done
for.
here in KKESH is just to try it in like an divide into groups and then just look in perspective whether you want to give.
So that's an interesting measure for prophylaxis in cataract surgery. Now we'd have to consider it in our combined cases, see if we'd like to do that.
And then you can just
Yeah.
look into the two groups. That would
We
be
don't
great.
do it. I don't know if any of you does intracameral antibiotics when we do combined surgery. You do, Dr. DB?
That goes with vancomycin, yeah.
Yeah. Yeah. Reproduction, yeah. Yeah, that's basically the reason why I did this, because we had a small cluster, I guess we can consider it, a few months ago, where like 4 or 5 patients came, and it really raises your awareness, and you say what's happening. You start going back and see what the measures are. Basically, we take all the measures. In fact, I don't know anybody here that we use small gauge vitrectomy, but we still suture, and still the endophthalmitis appears. So. Yeah, it's not proper care postoperatively. Yeah. It comes in. So you mean after silicone oil? Yeah, so maybe then we just have to suture, right? And not leave it leaking or yeah. Yeah, possibly like that report by Steinmetz, where he had 2 cases that he managed them with antibiotics. They improved very quickly. So how do we know this was really infectious if his cultures were non-existent in one and negative in the other? So it could be inflammatory, yes. It's not the same, yeah. Adel.
I'm asking about at the end of this case, when you injected the antibiotics and then you injected silicone oil. So at this stage, was the retina actually flat? And
Yeah, so this patient had his surgery had been for a retinal detachment, and it was very turbid. Our view, there was some significant amount of corneal edema, so our view wasn't 100%. There was some areas of whitish material on the retina. We did not know if it was the laser that they had just placed 5 days before, or if it was the infectious or the inflammatory material. So we tried flushing it out, and whatever flushed out was what we took for sample. If it didn't flush out, we suspected that it was the laser from the retinopexy surgery. So we did air fluid exchange through that area and then on the nerve and re-injected oil. We were not, to be honest, 100% sure the retina was flat because our view could not warrant it. And in fact, the patient had redetached later, so he's, has to go again for surgery. But he has no infection.
Okay. The other question, so you mentioned that tamponades tend to cause, from the surface tension, you get less oozing of fluid into the eye. So would this make you more inclined to keep air at the end of most of the surgeries if you're...
Yeah, so the Pan American Collaborative Retina Study analysis, let me see if I can bring it up real quick. It's interesting because they had what, 21, they had like 35,000 cases, right? And they used gas in most of the cases. Gases is either air or actual gas tamponade. So look, like 2/3 of their patients, they tamponade with air or gas. And only a quarter of them with fluid and a quarter with silicone oil. So yeah, myself, when I do oil removals, like Dr. Hassan was saying, I usually like leaving them under air. Even the first day, they will be a little bit hypotenuse, but I'd rather have some type of tamponade in there than just BSS. So there, yeah. So the experience, obviously, with in managing post-vitrectomy endophthalmitis is very small because there's a very small number of cases present. So this is like a very personal decision that these authors have taken into account. Some reports in rabbits, they have said that the regular dose of vancomycin can be toxic to the retina. This is in rabbits. So, you know, some surgeons are wary if you have endophthalmitis for a patient that underwent surgery for an epiretinal membrane and he was 20/60, you know, you don't want to be toxic to the retina, so they decided to give half dose. Also, if you have gas tamponade into the eye or silicone oil as well, the bubble is going to be filling the majority of the vitreous cavity. So the antibiotic is going to be directly in contact with the retina, and this could increase the toxicity. Instead, if you have fluid in the eye and you inject the antibiotic into the fluid, it's going to dilute. It's not going to be the same concentration.
Yeah, this is what I'm really agree with, and that's what why.
Yeah.
Because it will be small, concentrated in part of the retina, and that's more toxic.
Yeah. Okay, thank you.
Thank you very much.
This is your. This one is yours.
No, I
Yeah.
have my own. Oh, that one.
Oh. ايه وين الديسكتوب؟ لا شو اسمه؟
اللي قصدك الفلاش اي فولدر افتح ذا ولا لا اي فولدر
تلقى على جنب
تلقاه
شلون؟ شلون؟
بالشكل
صدق والله لا سوي لي اياها
ممكن
بس
هاي تسويها
شلون عرفت؟
دكتور دائما الشورت
هذه
كت
تراشرز
ايوه اول ثلاثه هذه والشورت كت دائما الشورت كت اللي ما تسويه ويكون موجود
وين الكوز؟ ضاع
لا ان شاء الله موجود دكتور كبر عشان نشوف ايوه
كوز
سوي ذا كلوز بس لا تسوي كلوز تبي شيء معين اللحظات شيء خلاص
بريزنتر فيو
بريزنتر فيو تبي
كويستشن
خلاص
طيب السلام عليكم. نبدأ. ايش فيك؟ So we'll start now. First question. This is a 65-year-old male with hypertension. So what is the layer of hemorrhage in A and B? Question 2. What is the diagnosis? Second question. 45-year-old male presented with metamorphopsia. So what is the pathology in A, B, and C? So this is A, this is B, this is C. Question 3. A young boy presented with strabismus in his left eye. So what is the diagnosis? And what is the treatment? So this is at presentation. And this is after treatment. The right eye is normal. Diagnosis, treatment. So let me put it, what is the mainstay of treatment? So question 4. This is a 40-year-old male with decreased vision in his right eye. So where is the hemorrhage? And what is the most likely cause? So this is at presentation. And this is after treatment. You can see something here. What is this called? So this is the cause. 40-year-old male with decreased vision in his right eye. Where is the hemorrhage? This is A. B. What is the most likely cause? No history of trauma. No. Nothing. He's healthy. Other eye is normal. And there is no disc swelling. This is a peripapillary fluid because of something leaking here. And the ultrasound did not show optic disc druseness. If you were thinking of druseness. Question 5. This is post-vitrectomy for rheumatogenic retinal detachment. What is the diagnosis? And what is the treatment? This is after treatment. This is a patient post-vitrectomy for RRD. A, what is the diagnosis? B, what is the treatment? This is after treatment. So this is a bonus question. 16-year-old male with acute superior nasal scotoma in the right eye. What is the cause of the visual field defect? And what predisposed this patient to the condition? This question. So what is the cause of the visual field defect? And what predisposed this patient to the condition? What is the cause of the visual field defect in this patient? Why did he lose visual field? And what predisposed him to this? So quick, we'll repeat the questions again. So the first one is, what is the layer of hemorrhage in A and B? What is the diagnosis? Number 2. This is a 45-year-old male presented with metamorphopsia. This is A. What is A? What is B? What is C? This is a young boy presented with strabismus in his left eye. What is the diagnosis? And what is the treatment? This is a 40-year-old male with decreased vision in his right eye. Where is the hemorrhage and what is the most likely cause? This patient is post-vitrectomy for RRD. What is the diagnosis and what is the treatment? This is the bonus question. This is a 16-year-old male with acute subperinasal scotoma in the right eye. What is the cause of the visual field defect and what predisposed him to the condition? ممكن نجمع الأوراق. Yalla, who wants to do the first case? Sarah? Mm-hmm. Okay, so it's difficult to know if it is subhyaloid or sub-ILM. So we took him to surgery, and with the thought that there could be subretinal blood involving the fovea. You can see the blood is there. So we thought maybe there is foveal blood, then it has to be taken away or displaced. So what we did is we took him to surgery, and we induced posterior vitreous detachment, and the blood was sub-ILM, not subhyaloid. We had to build the ILM. And once we removed the ILM and the blood under the ILM, the fovea was spared. There was no blood under the fovea. Okay. So, we'll take the second question. Aziz. Okay. Yeah, Biduranj. There are studies, there are few reports on multimodal imaging of this. Three. Go ahead. So what is the mainstay of treatment? So the mainstay of treatment is ablative therapy. So ablative therapy could include laser or cryotherapy. Steroids, anti-VEGF are adjunct treatments, are not the mainstay of treatment. So all of these are helpful or help you to reach the stage where you can apply complete laser treatment or cryotherapy. So what is this here? Yeah. So this is a limiting factor for visual improvement. Who will take this one? Abdul. Yeah, so mainly it is subretinal. There is no multi-layer hemorrhage, but it is of different appearance. So this is yellow, dehemoglobinized. This is fresh, but it is all subretinal. Okay. Peripheral CMVM. So good. So what mention some causes of peripheral CMVM? Okay, uveitis, angioid streaks, optic nerve head druses. So we looked for underlying cause in this patient. We could not find any, so it could be idiopathic. So he received multiple anti-VEGF treatments. We elected not to do surgery at this stage because it's already dehemoglobinized. No point of displacing it. He improved from from hand motion now to 2100. Still needs more treatment. So go ahead. Yeah, Hamid. So displacing, you have to displace it. Okay, so the presence of subfoveal BFO has a detrimental effect on photoreceptors, so it should be removed as soon as possible. However, many times it is noticed immediately after surgery, and you weigh the risk and benefit. You have to go in again and remove it, but you want the chorioretinal adhesion to form, which takes 10 to 14 days. So, and the displacement does not involve a lot of manipulation. You just inject subretinal fluid through a 39 to 42 gauge needle, and this allows, then you do fluid air exchange. This allows the gas or the air to push the subfoveal BFO away from the fovea. You don't need to take it out. Some people go directly in an area that is not the fovea, like here, and try to aspirate it. It may not come completely, and then you will have to do the same thing. No, it is self-sealing retinotomy when you use 39 to 41 or 42 gauge needle. Sorry? This one? Yes. Yes. What I told you. We went in, we injected the fluid here. The fluid was extending from here to here. And we did fluid air exchange. The patient did the face down, then face down first day, then 45 degrees, reading position, and this pushed the BFO inferiorly. So there are multiple factors. He had RD, so you don't know if this is all because of this or because of the retinal detachment itself, and it affects photoreceptors. Yeah. Oh yes, it is from the periphery. It is not from the center. It doesn't come from a macular hole. It usually comes from the peripheral break. And there are many techniques that, or many hints or tricks that you use to avoid this from happening. So don't take the perfluorone to cover the breaks. But in this particular patient, it was of positioning. He was not positioning at all. So if he was positioning and perfluorone went subretinal, any bubble of perfluorone went subretinal, it would have stayed in the periphery with the RBE holding it in position. So, Abdul Majid. Good. Anyone has any question? Good. When do you want to start the case presentations? Now? على طول؟ طيب. يلا. Who wants to start first? Yeah. Introduce yourself.
دكتور اسلام بيها اي دكتور اسلام هل على Shall we start? نبدأ. Assalamu alaikum. I am Dr. Fahd Gledawi, R3 KKESH resident. I'd like to thank Dr. Sulaiman for his kind supervision. So, 9-year-old male presented with night vision difficulty noticed by his parents when he was 1.5 years of age, and positive consanguinity and positive family history of similar condition when affected brother. In systemic review, speech delay and fat intolerance with foul smelling stool but no hearing problems. On examination, the VA is 20/40 in the right eye and 20/60 in the left eye. IUP 20 mm mercury OU, anterior segment examination is within normal, and the fundus shows this is the right eye. We can see clear vitreous with dull foveal reflex and peripheral chorioretinal atrophy. It's bilateral, both eyes. This is autofluorescence showing peripheral hypo-autofluorescence in both eyes. So what's the differential diagnosis? Can anybody? Okay, excellent. So this blood test showing increase in ornithine, it's 811. This is the OCT shows macular edema in both eyes. And ERG shows flat retina also in both eyes. And this is the picture of the brother, the fundus photo. He has same condition. So our diagnosis is gyrate atrophy. And our treatment was arginine restriction diet and vitamin B6, Trosopt and Diamox for the macular edema. So gyrate atrophy is a rare autosomal recessive disease located in chromosome 10, a human hereditary deficiency of ornithine aminotransferase results in 10 to 20-fold increase of the level of plasma or the ornithine level, which is toxic to the RP and the choroid. Characterized by progressive chorioretinal atrophy that results in a progressive deterioration of peripheral and night vision and leading to blindness. Initially, patients complain of decreased vision and night vision, followed by sharply demarcated circular areas of chorioretinal atrophy with hyperpigmented margins in the mid-periphery of the fundus, mostly in the first 3 decades of life, and leads to blindness in the 4 to 7 decades. Associated with myopia, posterior subcapsular cataract, CME, ARM, and vitreous opacities. Other systemic associations, seizure, structural changes in the muscle and the hair fibers. So there is a relation between the CME and gyrate atrophy. According to the literature, CME occurs with gyrate atrophy late in the disease. In a study done on 21 patients with gyrate atrophy, they showed 43% macular edema, 5% it's bilateral. So diagnosis, the blood test increase ornithine and decrease lysine. Urine analysis increase ornithine. ERG is abnormal. Dark adaptation is prolonged. FFA sharply demarcation between areas of choroidal atrophy and normal choriocapillaris. Flat ARG in gyrate atrophy. Reta et al. Documented flat ARG in gyrate atrophy late in advanced disease. Treatment, arginine restriction diet, consider vitamin B6, and treatment of associations. The prognosis is poor with legal blindness occurring around the age of 50 from geographic atrophy. This is the picture of choroideremia. It has similarity with gyrate atrophy. Little bit we'll talk about choroideremia. It's X-linked chorioretinal dystrophy characterized by diffuse and progressive degeneration of the RPE and choriocapillaris. The G responsible is CHM, symptoms, nyctalopia followed by reduced peripheral and central vision. Signs, female carriers show mild patchy peripheral RPE atrophy and mottling, and males initially exhibit mid-peripheral RPE abnormalities that may, on examination, resemble RPE. Over time, atrophy of the RBE and choroidal spread peripherally and centrally. Treatment, early clinical trial of specific gene therapy for choroideremia involving the introduction of functional copies of the fault gene into the eye have produced promising results. Thank you. Any questions?
So good presentation, Pat. One thing is, when you mention, when you assess the cystic changes in the macula in patients with dystrophy, it's preferable if you say cystic macular lesion. You can use CME. We don't know if it is leaking or non-leaking. Some patients, when you treat them with carbonic anhydrase inhibitors, either topical or systemic or combination of both, some of them they respond very well, and some of them they don't. Some of them they have a paradoxical response where they get worse. Different regimens have been used in the treatment of cystic macular lesions. With carbonic anhydrase inhibitors, some patients they received topical, then acetazolamide was added. They respond, then they get worse over time. You can give them a holiday of treatment, then you reinitiate treatment again, and they respond again with a noticeable improvement in vision. So. Other techniques or other methods of treatment include intravitreal steroids. Thank you. Any questions? So it is usually given repeatedly if there is a response. But some patients, they don't respond to steroids. You can use Ozurdex or triamcinolone, given the risk of cataract, of course, and steroid-induced glaucoma. Okay, thank you.
Assalamu alaikum. I'm Abdsalam Tairi, R2 from KKESH. I had a case today. He is a 37-year-old male presenting with a blurry of vision for 1 day with a negative past history. For a social history, the patient is a smoker and a social drinker. This patient has multiple sexual partner, and on systemic review, there is no genital or oral ulcer or any skin rashes. So upon examination, the anterior segment exams is within normal, the IOB is within normal, and the fundus, as you see in this picture. The left eye is within normal, and the right eye, anyone can tell us what is there abnormal in this eye? Anyone? Okay. Okay. This one. Yeah. There is a yellowish or whitening of the retina along the arcade and the temporal area. For this patient, we did euphytic workup as a retinitis. Yeah. So this is the FFA. For this phase, anything you can pick on the same lesion in this area. Okay. We can see there is area of hypofluorescent and area of dot hyperfluorescent in the lamellar phase. And as we progress in this in the FFA, we see staining, or I mean increase in intensity. So as you see, so it shows the staining, early hypofluorescent, then late hyperfluorescence. So, and we did also OCT for this patient, and we saw like an RBE changes, or RBE pigmentations, but there is no edema or like detachment. We did visual field. It shows that there is an inferior visual field defect, which correspond to the same area of retinitis. And upon the euphytic workup, the lab workup, the patient turned out to be positive for syphilis antigen, as you see in the lab workup. The RPR antigen is positive or reactive, and the syphilis antibody is positive. Unfortunately, I didn't find a result for the TBHA assays. So this patient was referred for medical doctor for treatment for the syphilis. And upon follow-up, the patient lesions disappear, as you see in this picture, and the visual field defect also improved. So our condition here is posterior syphilitic pelycoid chorioretinitis, and this lesion usually comes in patient with HIV positive, but it can come also with a patient who is not HIV positive. And this lesion is like pelycoid. The word is pelycoid, as you see here. The edges. It can come also with, it is retinitis, and it can come with some degrees of vitritis. And it usually affects the posterior pole or mid-periphery. So this lesion can be associated with vitritis, vasculitis, and hemorrhages. Also, it can be associated with detachment of the RPE. And in the fluorescent, as you see, the FFA, it presents with the early hypofluorescence and late hyperfluorescence. So, in brief, syphilis is a bacterial infection by spirochete called Treponema pallidum, and it's primarily come through sexual contact, but it can come through maternal fetal transmission or blood transfusion. Syphilis now is very rare because of the penicillin, but start to, as the literature says, it start to happen or occurs because of the resistance to the bacteria and because of the man-to-man sex. Syphilis is given the name of the great masquerader. It can present with anything in the eye or in the body, but the most common presentation in the eye is uveitis. So as you see here, it can come with conjunctival lesion similar to the one in the skin. It can present with cataract and glaucoma. It can present with Argyll-Ribberston pupillary abnormality, which is the neurosyphilis. And it can present with any type of uveitis. And also it can present with corneal changes. So for the if we are suspecting syphilis, we can do some immunological and biochemical studies, which we can divide into non-troponomal tests and troponomal tests. The first one here is not directed to this antigen, while the other one is specific and directed to troponomal antigen. So we start with these tests. Venereal Disease Research Laboratory test and the RPR, and if we turn to be positive, then we can proceed to the troponomal test. Syphilis present with 3 stages: primary, secondary, and tertiary. And the primary will be like flu-like symptom with skin lesion, and the tertiary is like neurosyphilis and necrotizing encephalitis. So the treatment, or the main treatment of syphilis, as we mentioned earlier, it is the penicillin, the main treatment, especially if it is congenital syphilis or neurosyphilis. For those patients who is allergic to penicillin, there is another options like ceftriaxone or ampicillin, but it is not like, not like the effect of penicillin. So that's my presentation, and if there is any question, you can ask. Thank you.
Thank you, Salam. So, question to you.
Yeah.
Is it enough to do VDRL and RVR to rule out syphilis?
Mm-hmm.
So
Sorry?
Is it enough to do VDRL or RVR to rule out syphilis?
I don't think so.
So could it be negative
you mean,
while
yeah.
the patient has syphilis?
They can do the dark field microscopy and immunofluorescence as early and quick, but this one can miss. But for the RPR and VDRL, I don't have an idea exactly if it is negative. Does it mean that the patient is not? It rule out the syphilis? I don't know.
So it doesn't.
It doesn't rule.
No. So which one of these tests, if positive, it will remain positive for life? So it is called serological scar.
The antibody.
So the
This one.
yes, FTA,
Yeah,
ABS,
FTA,
and
ABC. Yeah.
MAHA are the ones that once positive they will remain
Will
positive.
remain positive,
So it is important in patients who have the advanced stages of the disease.
Yeah.
So you mentioned about treatment.
Yeah.
So how do you treat ocular syphilis? You mentioned about penicillin G, but
Yeah.
there are different regimens of treatment for different stages.
Yeah.
So anyone knows? So it is IV penicillin, but how is the dosage given? So the treatment of of the first stage is not the second or third stage of tertiary syphilis, right? So how do you treat it when it is ocular? Yeah, so it is treated as if it is a neurosyphilis. Good. Does anyone have any questions? This is a very rare presentation of syphilis. In my career, I have seen only one syphilis. and the second one was in the US. So 2 cases. We don't see it a lot, but it's a very interesting presentation of the disease. They recover 2020. So you can save the patient's vision and the patient's life with this. Usually it comes in, to be symptomatic, usually it comes in the posterior port. And very rarely that you catch them early, they may have some fluid. But many times they have this OCT finding. And if you search the literature, you will find OCTA findings, you will find the on-pass OCT findings. So you see some small dots picked up with the on-pass OCT that you may not notice clinically. This is a very interesting disease, yeah? So usually they resolve, and they don't have relapses. It is not like it is a recurrent disease. However, you should search for other STDs, including HIV, also sexual partners. Well, we referred him to infectious disease, and he received treatment. I'm not sure if they did refer him to neurology, but I guess this is their decision to make. But regardless, they will treat them as a tertiary syphilis, as a neurosyphilis. Yes, I have that one. The first one I saw was bilateral. This does not look like Ambi. Ambi has multifocal. It is a multifocal choroiditis. This does not look like a multifocal choroiditis. This is a placoid lesion with some RPE mottling, and there was this vasculitis on with it. Okay, thank you, Edson.
Assalamu alaikum. My name is Majid Al-Ataibi, R2. First of all, I would like to thank Dr. Sliman for his supervision. Today, our case is, we have patient, 52 years old lady. She have follow-up in KKESH as a case of keratoconus. She referred from anterior segment to retina due to incidentally discovered drosens. On history, patient have history of hypertension and diabetes, which resolved after bariatric surgery 5 years ago. Ocular history, she known to have keratoconus on hard contact lens and history of uncomplicated cataract surgery, both eyes. On examination, vision, it's 20 over 100, both eyes. With the pinhole, it is 20 over 70. The previous visual acuity chart, it's within this range since 2016. IOP, it's control, anterior segment exam, unremarkable. Fundus exam, there is a healthy disc and macula with the mid-peripheral drosens. So this is her color fundus photo. We can see the drosen, mid-peripheral drosen. If you are her physician, from history and from examination, what is your top differential diagnosis? Patient, old lady, keratoconus, middle age, yeah, 52. Okay. Okay, what else? She's old, she's 52 years, keratoconus, poor vision, history of bariatric surgery, and drusen. Incidentally discovered the drusen. This is the only differential? Okay, good. That's it? Okay. The differential patient denies nyctalopia. Differential diagnosis, it was retinitis punctata albicans and vitamin A deficiency. The plan, it was ERG and visual field and vitamin A level. Next visit, ERG, it was showed reduced photopic and scotopic response. Vitamin A level, it was low. It was 95. So the impression, it was vitamin A deficiency. The plan is refer back to her primary physician for management of vitamin A. Patient seen once after that in anterior segment. She is complaining of decreased vision, mostly night vision. At that time, she didn't receive vitamin A in that visit. So our topic today, it's a vitamin A deficiency after bariatric surgery. Generally, vitamin A, it's a fat-soluble vitamin. It is a vital vitamin for ocular function, for conjunctival and corneal epithelial service, retinal phototransduction, and retinal pigment epithelial viability. Patient usually presented with the nyctalopia, I mean if they have vitamin A deficiency, dry eye, and keratomalacia. Okay. Generally, the patient, the most common cause of vitamin A deficiency, it's more prevalent in developing country due to malnutrition. But in bariatric patient, the patient usually have vitamin A deficiency due to multiple factors, including decreased food intake, food intolerance, gastric secretion, and bypass of absorption surface area, plus dietary recommendation after gastric bypass, including low-fat diet, which is potentially limit the absorption of the fat-soluble vitamins. Does it mean that every bariatric surgery, every bariatric patient have vitamin A deficiency? The answer is no. It depends on bariatric surgery. Generally, bariatric surgery can be divided into restrictive, malabsorptive, and mixed procedure. So I will take you to a short journey to the general surgery. The restrictive procedure like gastric banding اللي هي ربط المعدة and sleeve gastrectomy اللي هو تكميم المعدة. Neither digestion nor absorption is affected in such surgeries. So we suspect that vitamin A will be within normal limit. There is one study done in 2006 comparing the vitamin A level in a control patient and gastric restrictive surgery, like gastric banding, no statistically significant difference in vitamin A level. The other type of procedure is combined procedure, which is Rho and Y gastric bypass. It is a major surgery. You see, they cut the stomach. They keep just the upper part of the stomach and connected with the duodenum. And so we bypass duodenum and proximal part of the duodenum. So it's a very large or major surgery. The prevalence of vitamin A deficiency after this surgery is 35% in 6 weeks and 18% after 1 year. The other surgery is pilopancreatic diversion. It is also combined procedure, restrictive plus malabsorptive. They remove the they just keep the proximal part of the duodenum and connect it to the distal part of the ileum, the last part of the GI. So they bypass duodenum and jejunum and proximal part of the ileum. So it is more aggressive surgery. The prevalence of vitamin A deficiency after this surgery, it's 52% after first year and increasing to be 69 after 4 years. So in general, vitamin A deficiency occur most often in malabsorptive bariatric surgery than restrictive surgery. What is the treatment? Usually the prevention is the key. There is most of the patient after bariatric surgery, they received vitamin replacement. Recommended daily dose for vitamin A, it will be more with the malabsorptive procedure. Treatment, the American Society of Metabolic and Bariatric Surgery, they suggest the treatment of vitamin A to be 10,000 to 25 international units of vitamin A orally. Okay, for if there is no corneal change. If there is corneal change, it will increase the dose to 100,000 international units intramuscular for 3 days, followed by 50,000 100 international units intramuscular for 2 weeks. So since we give the patient large dose of vitamin A, many of the patients with the vitamin A deficiency reported compliance with the supplement, emphasizing a possible need for parenteral supplementation of vitamin A. Since we give a patient a large dose of vitamin A, we have to keep in our mind the risk of toxicity due to replacement. The toxic dose is above 50,000 international units if the patient receives it for more than 3 months. One of the signs of toxicity is increased intracranial pressure and pupil edema. So bariatric surgery has with the time been evolving to more malabsorptive than restrictive procedure, and the prevalence of ocular complication is expected to increase. Generally, in the literature, there is a few case reports about ocular complication in bariatric surgery due to vitamin A deficiency after bariatric surgery. The real prevalence of ocular complication in bariatric surgery is unknown, but the rarity of clinic reports of symptomatic nutrient deficiencies with ophthalmic complication can also mean that no one is looking for them. Thank you. Any question? تفضل. No, just fat soluble vitamin A and D and E and K. Yeah. No. To vitamin A deficiency. I searched about it. I couldn't find any relation. In vitamin A, yeah. Okay. Okay. Any question? Okay. No more question? ايه دكتور تفضل.
Okay, thank you.
Welcome.
Next.
طيب بسم الله الرحمن الرحيم السلام عليكم. Ayman Al-Ghamdi, first year KKESH resident. I'll be presenting a case about sickle-cell retinopathy. And as you know, sickle cell is a hemoglobinopathy, inherited, and it's a common disease in our society. And it's something we might face in our career. So I'll start by brief history about the patient. He's 36 years old, complaining of decreased vision for 1 month with floaters. And no flashes or no history of trauma. The past medical history of the patient, he's known sickler, and he's an HIV patient on heart therapy. Past ocular history is unremarkable. So regarding the examination, the visual acuity for the patient is 20/200 in the affected eye, the right eye. Otherwise, the anterior segment examination is within normal. Now we'll take a look at the fundus photo. This is a fundus photo of the right eye, the patient complaining of decrease of vision and floaters, showing in organized vitreous hemorrhage. And as you can see, there is a temporal area of retinal hemorrhage in the right eye. And this is the left eye, as you can see in the temporal to the macula, sclerosed vessels. And this is the FFA. It's not clear because of the vitreous hemorrhage we saw. And there is an area of anastomosis here, and neovascularization. And also non-perfused capillaries here. Also, this is the left eye, showing the capillary dropout we saw in the other eye, and also the anastomosis. And this is OCT, showing temporal thinning. We'll elaborate more about later. We'll have another one showing later. Coming on. Yeah, I put the picture one clearer. Okay, I'm sorry about that. So, what's the differential diagnosis for the peripheral retinal neovascularization? It's a wide differential. We can divide it to major entities, which is the vascular ischemia and the inflammatory ischemia, and also the miscellaneous. So sickle-cell retinopathy and proliferative diabetic retinopathy, PRVO, and ROP and ocular ischemic syndrome. Also the inflammatory entity, which include the sarcoidosis, retinal vasculitis. It's very important to differentiate sickle-cell retinopathy from BDR. In sickle-cell retinopathy, the non-perfusion happens peripherally. In BDR, it happens in the posterior equator, starts there. And also the CFAN neovascularization we'll see later. So sickle-cell retinopathy, the clinical manifestation of this disease is divided by the neovascularization to two main entities, like the diabetic retinopathy, to non-proliferative sickle-cell retinopathy and proliferative sickle-cell retinopathy. This is the non-proliferative retinopathy. You can see also the silver wiring, which represent the previously occluded vessels, the salmon patch and the black sunburst. We'll have more pictures in the next slide. And also the angioid streak. So this is a picture of the salmon patch we spoke about. Also, it is in our patient. We saw it temporally. So this is a picture of retinal hemorrhage. It can be elevated or flat. And this is the result of the hemorrhage in superficial retinal vessels. And we can see the black sunburst, which represent RPE hyperplasia and migration. And now is the proliferative sickle-cell retinopathy, divided to 5 stages. Stage 1 is the arterial occlusion. Stage 2 is the anastomosis in the non-perfused areas. Stage 3 is the CFAN, and stage 4 is the vitreous hemorrhage. And finally, stage 5 is the RD and TRD that can happen. So the first picture on the left shows the anastomosis, the stage 3 CFAN, and moreover, more picture of the CFAN and in FFA shows the filling of the new vessels with the extensive non-perfusion we see here, and the leakage of these vessels. And if you're wondering what's the CFAN, this is a CFAN. This is how it looks like. وحتى بالعربي اسمه مروحة البحر. Okay. This is the stage 4 or 5 for vitreous hemorrhage, and 5 is the TRD or RD that can happen. This diagram is a summary of the manifestation we spoke about, non-proliferative and proliferative. And so any patient coming with any of the previous things we mentioned, the photos, needs a proper workup. So the 3 things that are important is the dilated fundus exam, the labs to screen the patient for sickle cell disease, and the FFA. And this is the new thing that we mentioned is the OCT. The OCT, there is a case, a prospective study published in the American Journal of Ophthalmology and by the University of Illinois. Speaks about the OCT benefit in sickle cell patients. So this is the thinning, temporal thinning, that also our patient has. Unfortunately, I put the wrong picture. Temporal thinning. So what do they found in the study is that thinning those who have focal thinning of the macula have also decreased sensitivity in the retina compared to those who don't have the focal thinning. So it's a useful way to monitor the progression of the disease. Finally, the treatment depends on the stage, either observation in the early stages or laser for the neovascularization. It's very important to pay attention if you give the scatter laser in patients with proliferative sickle cell, they're more likely to develop, they're more prone to develop retinal breaks and detachment than patients with diabetic retinopathy. Another thing is the vitreoretinal surgery is for patients with TRD or presence vitreous hemorrhage. To be cautious with the using of expansile gas because you don't want to elevate the IOP and cause more occlusion of the vessels. And with this, I conclude my presentation. Thank you very much. Any questions?
So nice presentation, Aina. So, do you think we should laser the left eye in this patient?
Well, it depends on the vitreous hemorrhage, if it's going to resolve or not. We might do something surgical.
Did he have vitreous hemorrhage?
No, sorry, I mean, yeah, the left eye, yes.
No, the right eye had neovascularization, and he bled, so we lasered him.
Yeah, the left eye does show non-perfused areas, and there is anastomosis.
Yeah, should we laser it or not?
Depends, I don't know.
Yeah, we don't know. So, given the progression in the right eye, you may think of doing it. But if he comes to you like this, without an envies in the other eye, you may watch him. You don't need to treat them. Some patients even come to you with the CFAN neovascularization that is autoinfarcted, and they don't need treatment. Actually, maybe doing treatment may worsen things with the laser treatment. I mean, because it can lead to vitreoretinal contraction of the vitreous in that area and pulls on the retina and cause retinal break. So you saw how thin is the retina when it is ischemic. So any questions? So if there is active neovascularization with hemorrhage, then you laser the ischemic area. You don't laser the same, the neovascularization. You laser the ischemic area like what you do in ROP, fever, and the list of differential that was mentioned. If there is no hemorrhage and the neovascularization looks active, I mean, it is not fibrosed, then consider treatment. If it is fibrosed, it looks white, or there is no vascular component in it, then you may only watch the patient. It may be autoinfarcted, and you don't need to treat it. Well, I don't know. I'm not aware if there are guidelines of follow-up, but I would do them like what I do in diabetics. After laser, you see them in a month. To assess regression, if they are still active, you do more laser treatment. If they are still in earlier stages, you may just watch them every 3 months, 4 months. For the proliferative disease, I can extrapolate from fever cases that has been used. Anti-VEGF has been used in those cases, even in stages that are not that do not have traction component there. But if there is a traction, you want to avoid. This is the question that I was asking. We don't know. I am inclined to treat the other eye. However, you may want to wait until they develop a neovascularization, as long as you are following them, but you don't want to lose them. I'm not aware of any. But if they bleed, it means that they need treatment. It is always more difficult to address peripheral traction detachment compared to posterior traction. Surgically, the retina is thin and is more prone to breaks. Okay, thank you.